welcome, guys. Well, first of all, I want to welcome everybody today to our kickoff of Ivy League Learning. So we're very excited to have you here, and this is something we're trying new. So these are going to be micro-learning events every other Wednesday from now until probably the holidays. That's kind of our plan at the moment. My name is Judy Thompson. I'm the Director of Clinical Education at AVA. And join with me for each Wednesday until we both grow old is Dr. Kristen Jacobs.
I don't know how much something like that costs, right?
Guys, if you're not going to be talking, if you wouldn't mind popping your mics on mute, and that would be lovely if you could. Don't worry if you can't. We can mute you on this side too. So Kristen will be introducing our speaker here shortly, and that's Dr. Judy, I'm going to say it, LaJoie. LaJoie. There we go. This is a very, this is a casual experience. This is, hey guys, we're here to answer your questions. We're here to bring topics that you might not have gotten at other places. And hopefully they're very relevant topics for what's going on. During the presentation, please ask questions. There's a Q&A tab within this. So please go ahead and ask your questions in the Q&A. If you're just popping in, if you put yourself on mute just for now, and then after we finish the presentation, definitely take yourself off mute so you can ask questions if you'd like to. But please use the Q&A tab for questions. And if you have comments, if you have questions, if you, not questions, but comments or any other topics you definitely want to see on these, put it in the chat and we will take that into account and we will try to go find a speaker for that. This is meant to be educational, fun, and social. So if you want to turn on your cameras, please do. Definitely open up your mics at the end and talk to our speaker and us. And with that, I'm going to turn it over to the chair of Ivy League Learning, Dr. Kristen Jacobs.
Good evening, everyone. Thank you, Judy. I'm just going to introduce our speaker tonight, and her name is Dr. Judy LaJoie, which I love saying that now. She's been a registered nurse for 31 years and currently works for BD as their chief nurse, and she's been doing that since 2014. And Judy is one of the architects of the Vascular Access Management Program at BD. So she's here to talk to us tonight about hospital onset bacteremia. So thank you for being here tonight, Judy. And I will turn this over to you for our first session.
Kristen, and thank you to Kristen and Judy for inviting me to speak at your inaugural, I can never say that word, inaugural, my Brooklyn accent gets in the way, episode of Ivy League. I think this is awesome. As Judy had said, let's make this fun and interactive. If you have questions, stop me. Let's make this organic and fun, right? I think it's all about learning. I think we all learn from each other. We learned some new things about already since we've been on the call for the past couple of minutes. So let's just keep it going. Let me share my screen. Let me know if you could see my slides.
You're good.
Okay, awesome. So let's get started. So what I'm here to talk to you today about is HOB, so hospital onset bacteremia, and some disease state awareness, right? Something new coming down the pike. I think people have been chatting about it for a while, starting to really come together. So I just wanted to touch on a few points about HOB. So when we think about HAIs, right? Increased costs, mortality rates, all of the, never events as it relates to CMS. What does that look like? What does that feel like in the hospitals that we work in, right? So if we look at it in the aggregate, right, we understand that 5% of hospital admissions result in a healthcare associated infection, right? What are the infections we're talking about? CLABSI infections, CAUTI infections, surgical site infections, right? Those SSIs, soft tissue infections from wounds, right? From pressure ulcers. Those HAIs can cost, billions and billions, as you see on the slide, right? 28 to 33 billion in excess healthcare costs. I think in the advent, in a post-COVID world where hospitals are spending so much money for everything, right? They're spending more money for labor, they're spending more money for supplies. There is no money to go around, right? There is basically nothing left So we also want to think about the patient experience, right? If they result in 75,000 deaths per year, that patient experience really isn't where you want it to be, right? Hospitals really function off of the triple aim, right? So when you think about that triple aim, what do hospitals want to do? They want to drive great outcomes. They want to drive those great outcomes to turn into good patient satisfaction, and then they don't want to break the bank doing it. So if you look at how HAIs really impact that triple aim, it's pretty impactful, right? There's a lot that really goes on. So what is hospital onset bacteremia, right? So hospital onset bacteremia and fungemia, right? It will be considered an infection. If everybody could just mute themselves, that'd be great. Thanks. So if you have a blood culture taken greater than day 4 of hospitalization that comes up positive, it will be considered, as per the definition, a hospital-acquired bacteremia or fungemia, right? So what does that mean? What is it going to do? So it can remove the need to show causality and temporal association with a central line, right? So if CLABSIs will be a subset, there are other things that can contribute to HOB besides just a CLABSI or a CAUTI, right? The complexity of an HOB, so it's more extractable from even those most basic electronic health records. We want infection preventionists to be off their computer trying to figure out what is and what isn't, okay, and get them out back at the bedside, right? Educating, reinforcing infection prevention, and then it removes some of the gaming from that CLABSI algorithm, being able to say, when did it really start? Is it really because of this? Could the blood infection be because of something else? So CMS being an educated consumer, right? So when you think about from the past, CMS wasn't always an educated consumer, right? And I think about it in terms like this. If I was at a restaurant and I ordered a steak and I wanted that steak rare, and they brought me the steak and the steak was well done, I would say to them, hey, I'm not going to eat that steak. That's not how I ordered it. I'm going to send it back. I am being an active consumer, right? CMS long ago, if you had an 89-year-old woman who used to come in for pneumonia, let's say, and the DRG on that was 5 days and you get paid $15,000, if that frail older woman, you know, who's really doesn't have a good steady gait, you know, you're her nurse for the day, you go in, you tell her, here's your call bell, don't get up without me, I don't want you to fall. She's so sweet. She sees you running around trying to do a whole bunch of different things. You get up, right? She gets up. Unfortunately, she falls. She breaks her hip. Okay. Medicare used to pay for that. So then she's in the bed and now she has a Foley catheter and she gets a UTI. Well, tack that on, right? And then tack on all the other things that can happen to her, right? So this $15,000 DRG 5-day stay can now turn into a 30-day stay costing $100,000 because of all these different things that happened to this woman. And CMS used to pay that bill. They kind of so they went from being a passive payer to being an active payer. And that's when your never events started coming down the pike. That's when this pay for performance came down the pike, where they said, hold on a second, time out, right? If a patient comes in, it's the responsibility of the hospital to safeguard that patient. And if they came in for pneumonia, you better treat them for pneumonia, treat them within that 5 days so you'll get your $15,000, but then make sure you treated them well so that they don't come back, because if they come back, you're not going to get paid, right? So there's been a lot of gaming of the system. And I think one of the other reasons why hospital onset bacteremia is kind of coming down the pike is to eliminate some of that gaming, right? Because at the end of the day, the thing that we want most is to take care of patients, take care of them well, and ensure that we've taken care of them so well that they're not going to come back for the same reason. So why do healthcare systems care about HOB, right? You have in the literature, we know that we have a 17% higher mortality. We know, I could tell you just from CLABSIs, from all the literature that we review on a constant basis, the average cost of a CLABSI could be upwards of $45,000. I've been to institutions that have told me, huh, $45,000, I wish. Mine are up to $62,000, right? So some hospitals hone in on it so well that they know how much their infections are costing them, right? And then pyramid it, right? I'm getting more and more patients, right? I'm trying to do more with less. I have less staff at the bedside. They're a little transient. I have a lot of travelers. Not everybody knows my policies and procedures. Not everybody knows how to use my products. And you just have this compounding of issue after issue. The CMS penalty to be determined, it just passed, HOB just passed the National Quality Forum Patient Safety Committee review, where they did move it forward to say that HOB should be moved on and considered to be a CMS penalty by Medicare, by CMS. New evidence and KOL validation. So I think what's coming down the pike really is a plethora of different KOLs who are writing about the impact of hospital onset bacteremia and infections beyond CLABSIs, right? So all the work that Shelley DeVries does on peripheral line infection, all the work that we hear about coming from groups like the Avatar group, right? Really understanding all the parts and pieces that lend themselves to infection beyond the poor central line always getting blamed for everything, right? And then from an IDN perspective, right, I would want to care about HOB from an IDN perspective because I want customers, it's, at the end of the day, say what you will, it's a business, right? And I want patients to come to my hospital for care. I don't want a bad reputation that everybody in my hospital that comes here, that I have an inordinate amount of folks getting HOB, right, with that high mortality rate and then that high cost rate, because if I'm paying out all these penalties, I'm also paying out the cost to treat, right? So it's, I'm getting hit 2 different ways as an IDN. I'm getting hit from a perspective where I'm not going to get reimbursed, but then I'm also not getting paid back for the incredible amount of money that it costs to treat these complex patients. So I don't know if anybody on the call has heard, but the American Hospital Association did this really, really great white paper. And if anybody wants to read it, they can just do a Google search for AHA white paper on HOB. It was published in January. And what they did was they got insights from 200 healthcare executives and subject matter experts on the topic of HOB. And the information was very, very insightful. So the information, first and foremost, it was really, one of the first questions was, hey, who's already working on this, right? Who's really not aware of it? Who's aware of it, but just doesn't have the resources to get working on it? And what they said was 45% of the respondents were already tracking HOB, and another 20% plan to do so as soon as possible. When you think about HOB, what's interesting is that it's a two-pronged problem, right? Because the first thing that a hospital is going to have to do is identify on admission, right? So I remember when I was working in the hospital not that long ago, when the Never event came through for pressure ulcers, and the first thing we had to do was talk about how we were going to really take a deeper dive and look at patients as they came into the emergency room, or as they came in for same-day surgery, or day of admission surgery, or direct admissions, right? And really take a look at them to make sure that there was no breaks in their skin, that their skin was completely intact, because we had to document present on admission, or else we were going to take the ding for it in the back end, right? So as we think about HOB, same two-pronged problem, right? How do I identify that things are there, right, that are present on admission? But then also, how do I love on that patient different? Once I've established that they don't have a bacteremia or fungemia, how do then I make sure that I'm loving on them different so that they don't get one, right? So as you really think about that two-pronged problem, it's interesting to read the insights from this local work, how the perception of does it align with what Joint Commission and CMS is looking at? do the respondents identify best practices, right? Do they identify what should be in an HOB bundle, if you will, right? So I can feel people rolling their eyes thinking, oh God, I'm going to need another bundle. Now, what does this bundle mean? But when you think about it, if I'm a process person, right? So yes, I'm a nurse. I've been a nurse for 31 years. I love process. I thrive on process. And I feel like when you have process helps you not to skip steps, right? So I would have to deliberately skip a step in a process, and just skipping a step in the process negate what it is that I'm trying to do. Also, when you think about transient help at the bedside, does process not help them, right? Because we expect nurses at the bedside to be experts, right? But at the end of the day, are we not making them jack of all trade, master of none? Because we're asking them to do so many different things. Nobody ever wakes up in the morning and says, hey, I'm going to give someone an infection today. That's not how it happens, right? But because we have so many different parts and pieces at the bedside and so many different ways of doing things, right? Variation leads to risk. And if we don't negate that risk and we don't reduce that variation, how do we really help our folks at the bedside, right? So I encourage anybody to go on Google, look up that paper and read the insights. It's really, really interesting to see what these respondents said and what they're thinking about as HOB comes down the pike, right? When you think about how preventable is preventable, looking at it from a perspective of rank as a contributor, but then also rank is preventable, right? Like I said, I sound like a broken record, but when we first started going down this pike as it related to pressure ulcers, it was like, well, there are some people that are just, you just can't prevent it, right? If I have an ECMO person who's on 1 million pressors and I can't move them and they have, this incredible line coming out of the leg, what does that look like? Kind of putting that in the same bucket as HOB, right? Are some infections preventable? If they are, where do they rank and stack on this list? What is the perceptions leading to contributors of HOB, right? So you can see from the list here, central line is right there, first and foremost, with Caudy's right behind it at 21%. But again, very, very interesting to kind of see how it all falls out as perception amongst these 200 subject matter experts as well as healthcare folks. And then if HOB does occur, where can we have improvement, right? So the survey consensus said almost 40% of those BSI patients are on the wrong antibiotic, right? So this was an interesting thing. 40% of HOB BSI patients are on the wrong antibiotic therapy for as long as greater than 2 days after that blood culture is taken. So when you think about it, that delay in care for that 2-day period where I could really be maximizing that patient and I'm giving them the wrong antibiotic and I kind of have to start all over once that culture comes back and I really realize what the pathogen is, right? So just questions for you to think about. Like if you were a patient, how would those stats make you feel, right? What does that do to your confidence level as you're going in to be treated for an infection and your safety, right? What if you were a physician or a nurse? Did you realize that there were those kinds of delays as it relates to treating a patient for any kind of bacteremia, right? And then if you're a hospital administrator, how do you move the needle faster to make sure that you get better and faster identification of those bugs so that you can get the appropriate therapy going, right? So HOB is new coming down the pike, right? There's a lot of speculation as to when it will happen and how soon will it happen and what will the penalty be and what does it mean? So way more to come, but I just really wanted to start that conversation and that kind of disease state awareness and introduce you to the AHA paper because I think it has a ton of good content in it, just to kind of get the conversation going about, hey, who's doing what for HOB today, right? And if the answer is nothing, you're not alone, right? There's a lot of people in that same boat who are just not there yet. So just wanted to kind of open it up. Those are all the slides that I had for you today. Just wanted to talk about it quickly because I really wanted to open it up to questions, to really have a conversation about HOB. What are people thinking? What are people feeling? And that's what I have for today.
Well, what you had was wonderful. So thank you. That was great.
Thank you.